Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Laboratory here at California State University, Sacramento. This is Justin, one of my Doctor of Physical Therapy students. He's going to be serving as a model today as we examine the structure, function, and pathology of the musculocutaneous nerve. If you think of the name musculocutaneous, it has both a muscular component and a sensory component, or cutaneous. Its origin is the brachial plexus. Specifically, it comes from the terminal branch of the lateral cord. Lateral cord is developed from the anterior division of the upper and the middle trunks of the brachial plexus. Upper trunk receives C5, C6 fibers, middle receives C7. So its lateral cord is C5, C6, C7 nerve fibers, and that's going to be the same as the musculocutaneous nerve. So those are the nerves, fibers that are going to both provide sensation to the skin at those levels and also innervate the muscles. So if we think of the musculocutaneous nerve, it's going to start by going down the arm. It's going to run down underneath the clavicle, under the pec minor. In this area is pretty much, once it gets the lateral cord, once the lateral cord gets under the pec minor, then the terminal branch is going to be the musculocutaneous nerve. And it's going to run down like this, and it's going to run down on the lateral side of the coracobrachialis, and it's going to go between the biceps and the brachialis. So in essence, it's going to go between those three muscles, the coracobrachialis, and which is originating on the coracoid process, and it's going to come down and insert into the middle third of the arm on the medial side. That's the coracobrachialis. It's going to run between that muscle, and that's a C5, C6, C7, primarily C6 for its nerve innervation. And if we get our pin out to represent a force vector, so the force acting on the arm is going to kind of go up this way from the coracoid process. So it's a good position to flex the shoulder up, as you see here. And also, if the arm starts out over here, it can horizontally flex, coming in this way. And so that's the first muscle. It's going to innervate. Then it's going to innervate as it runs between the biceps and the brachialis. It can innervate both those muscles. The biceps has two heads, has a long and a short head. Short head is going to go ahead and originate at the coracoid process, part of the conjoined tendon, along with the coracobrachialis. And the long head, actually I'm going to get my scapular bone out to illustrate this. It's going to come up and insert into the supraglenoid tubercle up here, about half the fibers. The other fibers are going to go into the posterior superior labrum. So every time the biceps contracts, it's actually some of the force is trying to detach the labrum from the glenoid. This is sometimes a problem in overhead throwing athletes where the biceps have to be used to slow down rapid extension. And over time, some of this labrum can be detached, resulting in a SLAP lesion, superior labral tear, anterior to posterior in direction. So that's kind of a clinical significance of the long biceps because of its attachment into the labrum. So you get the long biceps more on the lateral side, the short biceps on the medial side. And with Justin's palm facing up in a supinated position, these muscles, because they cross the shoulder, they can help flex the shoulder. Go ahead and demonstrate that. Up like this, good, and then come down. But their primary function for the biceps as well as the brachialis, which is deep to it, is to flex the elbow. So go in and show elbow flexion. And then the biceps are also, especially at 90 degrees here, a powerful supinator. So starting with the palm down, it can supinate the forearm. So go ahead and supinate, there we go. So it's a powerful, and you can see the muscle contracting to do that. So the biceps are going to insert into the radial tuberosity, and then it has bicipital aponeurosis that flare medially in the deep fascia of the forearm as well. So those are the basic functions of the biceps. Again, primarily C5, C6, does not have the C7, and of those two levels, C6 nerve fibers is the primary innervation of the biceps. Deep to it is the brachialis, which originates on the middle third of the anterior humerus, and then it's going to come down and insert into the coronoid process of the ulna. Since it inserts only to the ulna and not the radius, it's a workhorse at the elbow, produces only elbow flexion. So go ahead and flex your elbow up, but it does not produce any supination, pronation type movements. Only muscles that insert into the radius can do that, and that's why the biceps can supinate. So they're also C5, C6, primarily receiving C6 nerve fiber innervation. So with a pathology to the musculocutaneous nerve, it can happen a few different ways. Like anterior-inferior dislocation of the shoulder could potentially stretch the nerve, or trauma within the arm. It's fairly well protected as it runs between the biceps and brachialis, so it's not a real common injury. But those are some of the motor deficits you could have: weakness in elbow flexion, supination, maybe a little bit of weakness in shoulder flexion as well for that. So that's the muscular part of the musculocutaneous nerve. Then once it leaves the arm and enters the forearm, on the lateral part of the forearm, the continuation of the nerve is sensory only. So that's the cutaneous part of the name musculocutaneous. So on the lateral arm, it's going to provide sensation, so it supplies the skin. So if you have an injury to the nerve, you could have abnormal sensation along the lateral forearm, rather than at the arm, the lateral forearm. And this is formally known as the lateral cutaneous nerve of the forearm, or even more formally, another name for it is the lateral antebrachial cutaneous nerve. So you can get pins and needles, numbness, tingling sensations along the lateral forearm with an injury to the musculocutaneous nerve. So that is a summary of the structure, function, and pathology of the musculocutaneous nerve.